You are watching the medical segment of the Jennylyn Show, and I'm Jennylyn Gleave, your host. On this segment of my show, various physicians will be debunking myths associated with their specialties and sharing what is new and cutting edge in their fields of medicine. Today, Dr. Kaisler-Meza of SpineOne will be debunking medical myths associated with chronic back pain and other back conditions, as well as the treatments and medications that have proven to help people with these problems. Stay tuned. You may discover you too have believed some of these myths. So here is your chance to find out the facts and make changes if necessary. Here is Dr. Meza.
Kaisler-Meza. I am a board certified in physical medicine and rehabilitation, or what's also called physiatry. I've been practicing in the San Jose area for about 20 years. I enjoy my practice because I get to see a wide variety of patients, both in the hospital. I'm the medical director of the inpatient rehab unit at Good Samaritan Hospital, and also one of the co-medical directors of this facility, SpineOne, where we've been open for the last 6 years. We treat mostly people with spine injuries, both people who've hurt themselves at home or at work. And we have a group of machines here. It's called DBC, and I'm proud to say we're the only facility in California that has this type of equipment. I have an office practice as well, where I see a variety of patients, people who've, as I said, hurt themselves at work, or people who've had strokes and need care after their hospitalization. So I've been asked to talk about the treatment of pain, and very specifically chronic spine pain, and that has this type of equipment. I have an office practice as well, where I see a variety of patients, people who've, as I said, hurt themselves at work, or people who've had strokes and need care after their hospitalization. I hope that I can somewhat debunk some of the common myths that are out there about spine problems, because it's a very common condition, and in fact, it is the #1 condition that pain-wise that people go to their doctors for, which is back pain. Back pain is very real. Like I mentioned, it's the #1 reason why people go to their doctors for pain. Back pain happens to approximately 1 in 4 Americans in their lifetime, and even more so, recurrent back pain. It's a very real condition, and it's a very debilitating condition for many people. It's one of the main reasons why people miss time from work. It's one of the main reasons why they miss out on life, because of their back, including their neck, their mid and low back. And it isn't in their head. The perception of pain is certainly what they say in their head, but that's because that's how people perceive pain through the nervous system. But the anatomy of the spine is very real as far as it being a source of pain, and that's something that we treat here all the time. It's interesting because people will come to me and they'll be in this horrible pain, and they'll have an MRI and they'll show it to me, and it is relatively normal looking. And people, I'll try and say, this is good news. You don't need surgery, there's nothing horrible going on, and they will be in horrific pain. Conversely, I've had people who their MRI was terrible looking. It was multiple discs were damaged. I thought that this person might need surgery, and they came in saying that they ate. And so the bottom line is that in medicine, what we're taught is don't treat the picture, treat the person. And that's important because then that deals with trying to treat the person as a whole person. What are they doing that's causing their pain? What might they be doing that's aggravating their pain? The degree of severity of the pain doesn't always correlate with the picture. And in fact, that's a very common scenario. The unfortunate part about back pain is that many times it does become a chronic condition. But most conditions in this country are chronic. That's high blood pressure, asthma, diabetes. That doesn't mean that you can't do things. It doesn't mean that you can't enjoy your life. It just means that for some people who develop a back condition, it will be a chronic condition, meaning that they'll have moments when they're relatively pain-free, and they'll have other moments when they have flare-ups. And a certain percentage of individuals who've had a back episode, they will unfortunately develop recurrent symptoms, but that doesn't mean it can't be treated successfully. It just means that they need to be educated on what to do for themselves. I wish that surgery could cure everything. Actually, I take that back because then we wouldn't have this facility. But surgery is a very good option for some people. But it is, I think, in my opinion, it is overused. In my opinion, people must understand that surgery may not necessarily cure them. It may help them, for sure, but it will not cure them. And the problem, of course, is that with surgery is that there are risks, and there is no guarantee. But it's not to say that surgery may not be beneficial for many patients. What we do know is that the great majority of people with spine problems do not need surgery. And that is a statistic that has been borne out in every medical study. MRIs are not necessary to begin the treatment of someone with back pain. There are what we call in medicine red flags that a patient may present with that a doctor should order an MRI right away. So for example, if they fell, if they have a history of a cancer in their family, if they have any signs or symptoms that suggest cancer, if they're reporting true weakness in their legs or in their hands, not related to pain, but true weakness, then a doctor should order an MRI sooner rather than later. But that's the infrequent presentation. Most people come in, they have back pain, they maybe have a history suggestive of a slip disc, and that's maybe. You don't need an MRI right away. Now, having said that, if the treatment that the doctor prescribes doesn't work or is failing, then it's time to kind of go back to the drawing board, and an MRI might be indicated. But I would say of the people that I see who've had back pain for 1, 2, 3 months, I don't immediately order an MRI unless there is a red flag. If you take Tylenol or Aleve or Motrin and over-the-counter medications and your back pain goes away, that's an encouraging sign that what you have might not be serious in the sense of something really physically or anatomically wrong, because those are relatively gentle medications. And if they help, that's, I think, good news. What I would say and suggest is that if you end up having to take these over-the-counter medications every day for weeks on end, and even though they might help in the moment that you take it, but you find that you're taking it again, and then the next day again, and then maybe 2 or 3 days later again, then something else is going on, and then you need attention. But lots of people have back sprains. They do a little bit too much gardening, and their back hurts. They take some Aleve, they feel better. That's okay. And as long as it goes away, I think that is fine. But it's when I've had people come to my office and they say, oh yeah, Motrin really helps. I go, good. How long have you been taking Motrin? 6 months. That is something that needs attention. The best patient is someone who comes in, is open to a discussion about their condition, doesn't solely rely on what their neighbor says, doesn't solely rely on what they read on the internet, because though the information on the internet is often very valuable and accurate, it is sometimes a little misleading. Just because a certain treatment you found on the internet helped a certain group of people doesn't mean it will help you. So I think the best patient is someone who's armed with information, but someone who's willing to come and hear someone who is experienced in their condition offer an opinion, a diagnosis, and is willing to work with the patient on a treatment plan. Opioids are not designed for chronic pain. Opioids, narcotics, are designed for predominantly acute pain. You fall, you break your ankle, you have surgery, you need pain medicine. If you have, God forbid, a cancer, a chronic cancer or a terminal cancer, you might need opioids, and you should get them in a judicious way. But opioids are not designed for chronic musculoskeletal or chronic spine pain, and people should not be on chronic opioids for those conditions. The chances of that are slim in people who do not have a history of addiction. But in individuals who do have a history of addiction, even for example, smoking is an addiction. People have a family history of addiction. There is certainly a chance. But for the individual who has a spine condition, who's in pain and is prescribed opioids, the chances that they'll have addiction is very rare. Now, all of us will become dependent on the opioid. And what that basically means is that if you stop the medication, you will have physical symptoms of withdrawal. That happens to all of us. Other people also will grow what's called a tolerance to opioid medications, meaning that today you need 2 Vicodin to help your pain. 6 months from now, you need 4. A year from now, you need 8. And that's because the body grows accustomed to the opioids. That's different than addiction, where the person starts behaving differently to acquire the drug. First thing you're taught is do no harm. And I take that quite seriously. My job is to help my patients, educate my patients, but do them no harm, which means not have them become addicted. And try and limit the amount of opioid medications. But it is important for the physician to be aware of the signs and symptoms of addiction. It's also important for the patient to be honest and tell the doctor, I'm having problems controlling how much I am taking. It's okay to say that, and then the physician should work with the person on how to address that. Some people who have back conditions, they start to limit what they do, and progressively they limit themselves more and more and more to the point where they essentially just stay at home and do very little. And they do that out of fear because they're used to pain. And the body just keeps sending them the message, you hurt, and they keep limiting themselves more and more. And this is where a person needs to come to get therapy, go to a physician to be educated and kind of relearn not to do that. But do it with advice, do it with education. And that's part of what we do here. 20 years ago, we used to tell people with any condition, just lay in bed. And now we know that even after a significant heart attack, we tell people the next day, get out of bed. because we know that bed rest does much more harm than good. And the reason why I gave you that example is that if we feel confident that someone who's had a heart attack can get up the next day and move out of bed, I would hope that people would feel comfortable and safe that they can get out of bed even though they hurt. It is imperative that you get out of bed. It is really, really difficult to start teaching people the confidence they need to get out of bed if all they do is stay in bed. That is true in several cases. This goes back to what I was saying about what's called tolerance. The body gets used to narcotic or opioid medications. And it's not because you intended to take more, it's because your body grew used to it. And so for one moment in time, as an example, 2 Vicodin a day allowed you to be functional and get up and do things. But later on, you need more. That is because your body has become tolerant of the medication. It's a real thing, it's a real phenomenon, and it's something that you have to acknowledge to yourself, and you have to tell your doctor, I'm needing more of this drug for the same effect. So it is a real issue and something that needs to be addressed. An example with spine problems, you may have a condition that doesn't completely go away. But like I gave the example of diabetes and hypertension and so forth, you can learn to control it, and you can learn to live with it, and you can learn to manage it. And what that means is that you can resume activity, you can do so in a safe way, and not limit yourself the way you are limiting yourself right now. Certain back conditions can lead to paralysis, but that is, I would say, rare. What paralysis implies, real paralysis implies that you have a nerve injury that prevents your brain from communicating, for example, to your leg. That does happen, but it is infrequent. There are certain back conditions that do cause that. And this goes back to seeing a physician who is an expert in this and can educate you on, number one, what needs to be done to make sure it doesn't happen, and also can address it if it does. So yes, it has happened. It's happened to my patients, and they have needed surgery right away when it's occurred. Some people tend to focus on their upper body, and they're very muscular and toned, and their pectoralis muscles, their upper back muscles, their arms, but as far as it relates to spine conditions, that won't help. What prevents spine problems is good mechanics. You don't even need a lot of muscle mass to prevent back problems. You need muscle tone, you need flexibility, you need endurance of your muscles. But you would be incorrect in thinking because you are a weightlifter, you are exempt from back pain. Narcotics are actually, I would say, down the very last of options when it comes to back pain. Now, if you slip and fall or you hurt yourself by directly impacting your back, you might need some pain medicine for a few days. That's reasonable. But if after several months you're still taking narcotics, that's actually counter to what we know is best for individuals with back pain. What we do know helps people, and this has been borne out by multiple studies, is activity and exercise. And this is what we try to accomplish here at SpineOne with our facility that uses as part of kind of the foundation for therapy a string of treatments called DBC, or document-based care. About 7 years ago, I partnered with several physicians to create this facility, doctors Ronald Fujimoto, Michael Post, and Darrow Brugger, and we opened up this facility called SpineOne. And what we wanted to find was a series of equipment pieces that we would be able to challenge individuals and help them regarding their ability to recover from back conditions. And we did a lot of research, and we found this equipment called DBC. And as I mentioned before, we're the only facility in California that has this facility, this equipment. One of the things that I think we found to be really remarkable about this, and as Roy is showing here, it runs through the spine range of motion. In other words, it runs through what we call flexion, extension, side bending, which is what Roy is doing. But what it particularly does is that it locks the hips. Many times what we find with individuals with spine conditions is that they're scared to move. They hurt. And what they tend to do is use what's called accessory muscles. They tend to rely on their hips for their movement. And this equipment, in all of the equipment here that runs them through all of the range, it locks their hips so that the movement is occurring in the spine. And what that does is, number one, is that they start building some confidence in themselves that they can move. On range, then endurance, safety, building confidence, and then afterwards we focus on weight. So we move people from this type of equipment to kind of more focused lifting heavy weights based on their tolerance. And with this type of approach, we've been very successful in helping individuals with both acute pain, subacute pain, and chronic pain. We've had individuals with pain 10, 15 years, and not that this is magic, but what they've learned is how to function better with their pain.